the peds imaging again. We've done a few last week. We'll continue this week. Well, I gather that we'll be off next week إن شاء الله مش كده ولا إيه؟
إن شاء الله.
And we start Saturday the 13th. Is this true or this is myth? محمد الصغير هنبتدي يوم السبت تاني ولا هنبتدي يوم امتى تاني؟
احنا هنبتدي بقى البريك الاسبوع الجاي، فكده هنبتدي السبت اللي بعد الجاي
بالظبط، يعني السبت اللي هو 13 ان شاء الله ان شاء الله
باذن الله باذن الله.
خلاص يبقى and on that day ان شاء الله we'll start with anesthesia. Once we're back I've got a lot of يعني emphasis that will be real life again on the 20th. I hope it's true. If this happens بقى we'll get going with the clinical and a lot of other things. فمثالي دي كنا شفناها يا محمد، هنغير دي ونور انت السبوكس بيرسون دلوقتي. They will be going on with the images until you're maybe bored or fed up or whatever.
Okay.
اوكي
دي شفناها يا دكتور؟
مش عارف انهي، مش شايف انا دلوقتي، اشوف حالا. انا بشوف دي شفناها، دول السي تيز اللي هي كانت الامبريوما. This is the nephroblastoma that we had seen last week. And this is the neuroblastoma that we saw last week also, pre and post chemotherapy. This was the intussusception that we saw that Zain was talking about, the very last image. This was the image of intussusception. Get that inception. This image in particular is not clear. Maybe it's the other one that is clearer. Oh, the intussuscepting loops. That I don't know who was talking about intussusception theoretically. It was probably Khalid. So we've done all these things. We've done neuroblastomas, nephroblastomas, كمان intussusception, Perthes, if you remember Perthes disease. We've also seen a stone of the urinary bladder. I don't know what else did we see, but anyways, we'll continue. يلا يا نور. قول لنا what's
Okay.
this
the X-ray skull.
Yes, absolutely.
Wow.
What is the projection? What is the projection?
Any projection?
يعني AP, lateral, oblique, whatever it is. How did you project the X-rays?
الجنب يعني.
It's a lateral. It's a lateral view. It's a lateral.
Lateral view.
It's an X-ray. It's a lateral view of the skull. Yes. Obviously, if you say it's a skull X-ray, then you mean a plain film. You mean a plain film, or is this a contrast?
No, plain.
Plain. Where can you put contrast in the skull? If you talk about contrast skull X-rays, where are you going to put contrast?
في ventricles مثلا.
Maybe.
يعني بنديها من اللمبر مثلا أو حاجة عشان يرسم.
Yes, maybe, but obviously we've stopped doing that because we've now got beautiful images that do not require that with the MRI. So لكن صح, absolutely.
ممكن في برضه Venus IV مثلا.
تمام.
Salivary glands.
Visualize the carotids and maybe the sinuses and so on. Okay. يلا, what do you see on this plain film of the lateral view?
احنا شايفين مثلا التيث دي مثلا لسه هتطلع مثلا.
تمام. يعني you're dealing with someone who is
young.
Yes. They're young, yes. I'm sure. An unerupted wisdom tooth. They're young. They seem to be young because of their size and the way the thing looks, yes. What's happening with the skull popper? What is the skull popper? Shows something.
ممكن اللي هي الدوائر دي كده في دوائر
الدوائر
كتير
دي.
كده.
تمام دوائر يعني what do you mean by دوائر describe them صح I agree that this is the appearance describe them in radiological terms that is radio dense radiolucent
هو
whatever.
الوال بتاعهم دوت راديو دانس مثلا
مم.
ومن جوه من جوه يعني لونهم يعني زي البون يعني مش عارفة يعني لونهم زي
You
النورمال تيشو كده.
cannot not know because it's just you want to say that they're less dense in the middle and they're got a rim of radio density or increased density. That's the only thing you want to describe. It's nothing about not knowing. طيب in the periphery, how about in the periphery? How about in the how do you call it, the upper part of the skull, but whatever this is the
الفولت يعني
الفولت حصل لها ايه؟ The region of the vault, what is happening? يعني is it the same
calcified.
density? I mean it's just the densities. Just describe. Why don't you just describe? You cannot have a problem description ever.
It's hyperdense.
Hyperdense, like in just below it, is there an area of increased density or diminished density even more than the rest?
هو هنا في increased density وهنا في diminished density فوق.
لكن عند الفولت فوق عند الupper vault.
أيوة هنا.
The upper part بقى the summit of the skull, the summit, the part that is most superior. ايه اللي حصل؟ فوق كمان فوق خالص. الحتة دي مالها
فيها hypodensity.
فيها hypodensity. خلاص يبقى this is the description of the skull that you've done. This is a plain film of the skull. It's a lateral projection. This is someone young, as shown by the way their bones look, not only by the size, because the size obviously you can magnify and you can sort of diminish the image. The teeth are unerupted, the wisdom tooth is unerupted, and the skull is not homogeneous. It's full of areas of different densities. There are multiple areas with radio densities in the periphery and a bit of diminution density in the center. And at the extreme periphery of the skull, the upper part of the vault, there is a bit of even more and more diminished density. What is the diagnosis? Then we left to the diagnosis. Then there are three approaches: approach to the image, an approach to the findings, and an approach to the diagnosis. You may be able to diagnose.
هو ده ممكن يكون ايه مثلا opened fontanelle مثلا حتة اللي في ولا ايه؟
Are these the sites of the fontanelles? Are these the sites of the fontanelles?
هنا ممكن يكون كان هنا مثلا أو حاجة.
لكن what about the rest of the skull? What about the rest of the skull?
ممكن يكون عنده ايه atrophy مثلا.
افتكري do these indentations on the skull look like something? What do they look like anatomically speaking يعني anatomically speaking?
cysts مثلا.
Cysts, bone cysts, maybe they may be bone cysts. Yes, but bone cysts are probably they won't be that multiple. The skull is got this appearance all over. The cysts would appear maybe less dense. But anatomically speaking, could this be the impact of something that is present normally? Could this be the effect of something present normally? Suggesting bone myths. لا دي حاجة أنتوا عارفينها by the way. دي حاجة أنتوا عارفينها. It's much easier and it has to be diagnosed, as I've thought, by as a spot. You diagnose this as a spot. حازم دلوقتي بيقول this is cranial stenosis. He's diagnosing, but he did not yet mention anything about the appearance of
ممكن hydrocephalus مثلا وفي fluid كتير.
طيب hydrocephalus. طب محمد ممكن تفوت لنا كده الافلام نجيب صوره الهيدروكيفالس. في صوره هيدروكيفالس with
والهيدروكيفالس هيبان اكتر في الفنتريكلز يعني.
اهو بص يا رجعنا يا محمد، رجعنا تاني يا محمد، انت جبتها فوق ومشيتها. لا مش دي برضو، مش دي ولا دي، في واحدة يمكن دي شوية بس ايوه يلا شوفي هو شايف. ايوه دي يا محمد يلا.
دي حاجة كلها homogeneous hyper density بس homogeneous في السكال كلها.
Yes, and is the skull big? Do you think the skull is big?
Very big.
لا احنا عاوزين نثبت على دي بالظبط. شكرا يا سامي، متشكر قوي كتقرير. If the skull is big, how did you conclude? How did you think the skull is big?
in relation عندنا هنا هو باقي الماندبل وعندنا هنا رقبة الشخص.
تمام.
فواضح انه السكال out of proportion يعني.
تمام. Do you get skull X-rays nowadays to diagnose hydrocephalus?
لا.
Why don't you get skull X-rays to diagnose hydrocephalus?
عشان احسن ان احنا مثلا نشوفه في السي تي، هنشوف الفنتريكلز مثلا ونعرف السبب بقى، هل
عشان نعرف اذا كان ايه ولا ايه،
communicating ولا non communicating.
بالظبط كده.
بنشوف الفورث ventricle وكده.
We're done with we never get plain films. And at the beginning when CT was introduced in the 80s, radiologists insisted that you get plain film before you get a CT. You don't get a plain film almost at all nowadays. لأن طبعا CTs supersede plain films by far. You don't need to subject these children to repeated radiation or whatever means. طبعا gone these days. How was this baby cured? How was this child cured? أو not cured, treated, managed.
هيدروكيفالس؟
لا هو باين في الصورة.
حاطين له شنط. حاطين له شنطة، هو اللي هو بريتونيال، اللي هو بيمشي من الفنتريكلز
بالظبط.
بيمشي من الفنتريكلز للبريتونيوم.
بالظبط. BPS absolutely. But this is the appearance of the hydrocephalus, which is quite different. The head is markedly enlarged and it is homogeneous. The cortical bone is almost not seen. There's a shunt. There may not be a shunt, obviously, because they may have not been treated before. وبس. Let's get back to the. This will correspond to a very typical. يلا قول لنا بقى about what is the difference between this and that.
هنا السكال شكلها طبيعي يعني proportions منطقية.
يمكن منطقية يمكن بس يمكن الفيس برضه هو كبير بالنسبة للسكال. اوكي لكن definitely
يعني دي صغيرة ولا ايه؟
يعني I thought so, but at least it's not big like the other one that you've seen, at least, and the densities are different. Or Pradeep suggested this is microcephaly. You've got cysts, you've got metastasis, you've got craniostenosis, you've got microcephaly.
brain atrophy.
فأنا برضو عاوز أفكرك, do you think these marks on the skull, do these represent something normal present inside the skull, and these are its indentations or impressions on the skull?
الجيراي يعني.
بالظبط كده. يبقى could this be a microcephalus? Could this be a microcephaly?
لا.
If the brain is
indenting
the skull and
هو صح ممكن craniostenosis ان السكال نفسها هي اللي ضيقة.
بالظبط كده.
والبرين بيحاول
بالظبط. These are not metastases because they're too early to be metastatic. يعني it's all over. So this is the appearance that we call, this is increased intracranial tension inside the skull because the skull is
كان ground glass appearance تقريبا كان موجود في الكرينيوستينوزس في الأطفال.
ground glass ولا بيقولوا عليه حاجة تانية؟ بيقولوا عليه حاجة تانية. It's just like one of these manual workers who work with precious metal and they keep beating.
أيوة كان اسمها موتن إيتن مش عارف.
Precious moths are not precious, but a precious metal. A precious
silver
metal.
beaten appearance.
بالضبط كده. This is the beaten silver or the silver beaten appearance. In an adult, this would equal increased intracranial tension. in this age group, because the sutures are not yet, you've touched on the sutures, because they're not yet fused, the head enlarges, but it doesn't cause an increased intracranial tension appearance of this in the play in a child. If this is زي ما انت قلتي كده craniostenosis. It would have been microcephaly if there were no indentations or no impressions on the skull, that of the brain. This is craniostenosis. وطبعا the skull is unable to enlarge to accommodate growing brain, and the brain leaves its impression on the skull, which looks like the calcine that you mentioned. وده اللي بيقول عليه beaten silver. I like beaten silver more than silver beaten. Like, and they're both correct, but beaten silver. It's the beaten silver or the silver beaten appearance. If you see, طبعا we've stopped seeing these in adults because nowadays, if you suspect a tumor of something in the head, you do not get a plain film anymore. You get a CT, or maybe in the trauma setting, but in the non-trauma setting, you get an MRI. I'm sure you know that. لكن ده اللي بيقول عليه the beaten silver appearance, and this implies increased intracranial tension. In a child, this is not possible because in a child the head grows rather than the pressure, rather than the brain leaving its indentation or impression on the skull. But this means the skull is unable to grow, which is زي ما انت قلتوا كده craniostenosis. انت اعطيته a beautiful DD، قلت دي microcephaly ولا دي lytic lesions ولا دي which includes cysts ولا دي craniostenosis. وصلنا by analysis that this is craniostenosis. اوكي يلا عشان نشوف اللي بعد كده. نور لو زهقتي في اي وقت او مليتي في اي وقت just say.
ماشي.
يلا قول لنا ايه دي، ايه اللي انت شايفاه دلوقتي؟
دي برضو plain x-ray، بس هنا بيسموه ايه antro posterior view.
This is an AP. How many modalities have you got to image the body? How many imaging modalities have you got?
5.
يلا elaborate. What are the 5? Yes. صح.
في x-ray، بعدين و CT و ultrasound و MRI و CT scans.
تمام. Whenever you're thinking about imaging part of the body, obviously you can apply any of the 5, but in a selective, in a priority form, and not just enumerate them. I can probably use any of the 5. Why did you mention CT after X-rays?
عشان CT were made بعد ال X-rays. ال X-rays هي أقدم modality.
Did you mention these in a chronological order according to their invention or discovery? Did you mention them in a chronological order?
لا ممكن ال CT scans تيجي قبل ال MRIs مثلا.
Definitely. MRIs, where we put MRI chronologically? Last thing ولا before the last ولا in the middle ولا ايه؟
مش عارفة هو الالتراساوند، بس أعتقد ال MRIs آخر حاجة مثلا.
بالظبط كده، ال MRIs آخر حاجة، ال MRIs آخر حاجة، لكن in fact I would expected your answer to be because CTs use X-rays as an energy form. يعني they use X-rays to image the body at the end of the day.
أيوه.
Chronologically X-rays، بعد ال X-rays جت مين؟ بعد ال X-rays جا مين؟
الالتراساوند أو لا CT scans.
ultrasound بس قبلها CT scans بالضبط. In the 80s we're still debating whether you would detect liver mets using CT scans versus ultrasound. Come on, gone these days. You never CT scan the liver. Nowadays you very rarely CT scan the liver طبعا. Not the biliary ده موجودين but the liver. فيبقى X-rays، CT scans، ultrasound, and then فاضل لنا حاجتين.
CT
ايوه.
وبعدين MRI.
امتى ال CT؟ when was CT invented؟
في ال 80s.
لا قبل كده، a decade before that, in the 70s. It's 1970. MRI was becoming introduced into clinical practice in the 80s. وخلاص 80s or maybe later 80s، يعني it was still introduced 80s or 90s كمان. Okay يلا ده بقى plain film of the skull. Yes.
ولا anteroposterior view وفي نفس ال appearance برضو ال indentations بتاعت السلقاي والجيراي على السكال.
تمام. Is the
أهي.
skull appearing small? Is the skull small?
السكال small
It's small. The face is really big and as compared to the skull. Maybe it's more
الفيس
evident.
مثلا الايز باينة، هي دي الايز صح؟
Yes, these are the orbits. Yes, absolutely.
فواضح السكال صغير.
تمام. This is the same thing, but it's a different projection. How many approaches are there to an image? When you comment about an image or comment an image, how many approaches are there?
الأول بنقول الموداليتي وبعدين بنقول الفيو وفي كونتراست ولا ما فيش كونتراست وبعدها
ده كله يجي تحت approach to the image. ده كله تحت approach to the image. The modality, the projection, the contrast, the reporter, the center, the man who was or the woman who was the image, the date. ده كله approach to the image. Any arrows or any marks, because they're important to take care of to note any arrows or marks that have been put by the radiologists. طيب وبعد كده approach to the ايه؟
بعد كده بنقول بقى بنشوف المكان نفسه وأي abnormalities فيه.
يعني
نشوف احنا مثلا في الابدومين.
Then you talk about the findings. Then the approach to the findings that may be number one. The findings may be زي ما انت قلت كده ايه؟
يبقوا
they may be
normal.
normal بالظبط او they may be abnormal. What abnormalities may you encounter؟ ايه الابنورماليتيز اللي ممكن الواحد encounter؟
ممكن حاجة مش موجودة مثلا.
يعني ممكن يبقى في باثولوجي، ممكن يبقى في باثولوجي، ممكن يكون في previous operation or intervention، ممكن يكون في evidence of the technique. ممكن you may see for example a stent
underwater
bypass
sear مثلا.
بالظبط plate and screws whatever يبقى ممكن you see evidence of intervention. You can see a pathology or you can see evidence of the technique, like for example a catheter to which you introduced the contrast for example. Or they may be normal. Okay. وطبعا at the end of the day what do you want at the end of the day?
To diagnose.
You want to diagnose it. You don't want just a description. You want to diagnose it. You may reach that from the very beginning, but if you cannot reach that from the beginning, you start describing, and you describe in radiological or imaging terms. مش عارف equilucent and a quick hot spot according back to the modality.
To modality.
بالظبط. Do not forget to provide radiologists with a lot of clinical data, because they just don't want just to describe lesions. They want to reach a diagnosis and help you reach the diagnosis. They should provide them with a lot of history. They'll not just request a CT of the abdomen. It's not the proper way. It's you should tell them something about the history, whether this man has got so and so, the pain, مش عارف اي حاجه. اوكي يلا هنكمل. يلا نشوف اللي بعد كده. اللي بعد كده probably احنا شفناها.
ادي الهيدروكافيلوس.
You can see the proportion of the skull to the face, and you can see that the skull is really enlarged. You can see the homogeneous density of the skull. There are no.
دكتور.
And there is the shunt. أيوة. مين اللي بيقول؟
أنا حازم يا دكتور.
قول يا حازم.
هو انتوا ليه قلتوا على ده ventricular peritoneal shunt؟ مش يمكن يكون هو مش في شنط بيكون متوصل بالرايت اتريوم؟ يعني مش يمكن يكون هو ده كده؟ ليه قلتوا بريتونيال يعني؟ نور والسيم قالوا
بريتونيال. هم اللي much more commoner than ventricular shunts. VPSs are I think the standard. لكن I haven't got enough clues to tell you whether this is so and so.
تمام اوكي.
بس الفي بي اس هي اللي بتتعمل by far commoner وبتعمل لنا ساعات مشاكل. VPSs are sometimes involved in peritonitis, and then there is a question of removing it or not removing it. And you can imagine that if someone develops a peritonitis and they've got a VPS, then it may be a problem.
تمام تمام شكرا.
دكتور طب هو مش ممكن يكون مثلا ديت blood vessels مثلا وده واخد contrast؟
يعني if
اصل هما
you
يعني عاملين كده وبعدين يعني
if you look at the carotid
مقسومة.
angiogram, at the carotid angiogram, you'll know that this is not a carotid. Okay, there's not one single branch. There isn't anything inside the skull anymore. I think that this is a ventricular peritoneal shunt. Okay.
اوكي.
يلا لو جينا بصي وسعيها شويه، كبريها، اعملها زومينج، هتلاقيها it's like a tube with two it's not branching obviously, and it's got two hyperdense walls and an area that is less dense in the middle. Okay. خلاص we'll go on. يلا shall we see something else? صح. The standard is the peritoneum. The standard is peritoneum. طبعا we
دكتور
don't
معلش
want
بس هو الميتنج ده فاضل عليه 3 دقايق، فبعد ما نخرج هنخش على نفس اللينك تاني.
تمام. مش هيمديهولنا النهارده بقى because this was our third time.
دي
فخلاص
تالت مرة تقريبا.
ثالث مرة، إلا بقى لو قالوا لنا فجأة كده إنه خلاص أوكي. دي نفس الحكاية يا نور، مش كده؟ دي نفس الحكاية برضو.
دي برضو سكال كبير. لا يونج،
age?
عشان كل التيث تقريبا ما طلعتش.
The teeth are not yet erupted. This is the same thing. خلاص بقى it's not as good as the others. This is already the same. خلاص يبقى ممكن نخرج elegantly بقى يا محمد، مش كده؟ بدل ما يقفلوا علينا نخرج دلوقتي ولا خلاص اللي بعدها؟
دي برضو سكال كبيرة، بس هو عاملة ايه، عاملة نفس الدوائر برضو.
نفس الدوائر برضو بالظبط كده. الدوائر برضو it's the same thing.
يعني دي craniostenosis برضو.
All the same thing. It's all the same
ودي
thing.
برضو.
How do you call it? How do you call the appearance? What is the appearance?
Silver beaten appearance.
يعني beaten silver may be better because
beaten silver appearance.
لكن silver beaten it's the same thing. You can think about it and they're both correct. But beaten silver follows the adjective being
أيوة makes grammatically أحسن.
بالظبط. لكن silver beaten برضو is not incorrect if you can think about it. بس خلاص يبقى هنكمل. يلا لغايه ما يقفل علينا بقى نخلص ونرجع ندخل تاني. يلا.
هنا اديت ده سي تي. وعندنا الفيوز هو متقطع من اول هنا فوق تقريبا لغايه ما وصل تحت.
فوق تحت بتاع ايه؟ من الرجل يعني ولا الايد ولا البطن ولا ايه؟
لا سكال. في السكال.
You should mention that this is a CT of the skull.
Okay. CT of the skull. هنا باين عندنا
really CT of the skull or CT of the brain? What would you suggest?
Brain. Both السكال والبرين.
يعني CT of the head بقى. CT of the head. Or that if you get a CT of the skull, is it different from a CT of the brain?
ممكن of the skull. هتورينا مثلا مش عارفة اللايرز بتاعت البون نفسه.
يعني how do you call it if you want to concentrate on the bone and blur the
bone
soft
window.
brain? A bone window. Then it's called the bone window بالظبط. Then you get a bone window. This is obviously not a bone window. This is a soft tissue window. Yes. What cuts are they? And how about contrast? What cuts? What are the cuts?
هو عندنا الكات ده supraventricular اللي تحت ده supraventricular.
يعني أقصد أقول are they axial, sagittal or coronal?
They are axial.
دول axial بالظبط كده. This will be your very first comment. This is it contrast enhanced? Is this contrast enhanced?
لا. No.
You don't usually get CTs of the head with contrast. It's as you can see.
احنا في يعني الليفل بتاع السوبرا فنتريكولار ما فيهوش حاجه. بعدين نيجي
اوكي
عند الفنتريكولار ليفلز. عندنا هنا اللاترال هورنز، قصدي lateral horns اسمه ايه؟ اسمه
ايوه
ventricle.
what is happening with these ventricles?
ventricles dilated.
They're dilated. Okay. You may have
ده
seen on the scanogram
وحتى
that the head is also the head is bigger than normal on the scanograms. Okay.
وحتى
Yes.
عندنا هنا third ventricle برضو dilated.
The third ventricle
اللي هو
is
في
dilated.
النص.
How
بس
how did they manage this boy again, or this girl? How did they manage this person again?
كانوا حطوا له الشنط من
يعني
الفنتريكل للبيريتونيوم.
is there evidence of this shunt or no shunt? في evidence of the shunt؟
هي في دايرة هنا، ممكن تكون هي دي الشنط.
شاوري عليها.
هي حطيت عليها سيركل.
هي دي.
موجودة.
هي دي بالظبط. and it's coming out of the skull. Can you see it coming out of the skull at a different level? At a lower level, you can see it coming out of the skull. اهي. شايفاها؟ It's coming out of the skull in the second row to your left hand side. ايوه. And in the upper rows as well. I don't know whether you can see it on the. You can also see it. Can you also see it on the?
أيوة اللي هي الحتة دي مثلا.
أيوة. فين الحتة دي؟ لا الحتة اللي هي أيوة
لا بس هنا هي موجودة في النص.
This is the one that Pradeep has shown us. Yes, and you can also see it. Can you see it on the scanogram? Nor can you see it on the scanogram?
هي اللي هي هنا صح؟ الحتة اللي هي الخط اللي فوق ده.
Absolutely. طبعا this again is but this is the CT. That is enlarged. You don't get any plain films anymore because they do not provide you with enough information. You get a CT. This is the standard. You don't get almost X-rays of the head anymore. They are historical. At the beginning, when CT was just being introduced, radiologists insisted that people get how do you call it, a skull X-ray before they get the CT. Come on, gone these days. You know how CT is being abused. Everyone orders a CT and everyone gets a CT. In a lot of hospitals, have a committee organizing the indications and the contraindications of using the different modalities and restricting the exposure to radiation. Come on, people who work in the radiology department have got a dosimeter. They've got a dosimeter calculating the dose of radiation they're exposed to. But radiation protection is a major issue where people who are exposed to radiation and when they are being exposed to these X-rays have got to wear protective gear. I don't know about a lead apron, goggles, maybe even how do you call them, gloves, and so on. They don't want the skin to be disturbed. They don't want their hair to be disturbed. They don't want their gonads to be disturbed. They don't want their bone marrow. They don't want the precancerous effect of the radiation. Come on, the walls. And what are the walls of the X-ray department? Are the walls of the X-ray department usually normal walls? Are they simply concrete?
لا بيبقوا تقريبا leaded برضو عشان
بيبقوا leaded absolutely بيبقوا leaded
يعزلوا
تمام.
الراديشن.
بالظبط. They don't want people walking close to the department being irradiated. It's very very unfair. They're leaded. وطبعا this is all about قولي
دكتور هنا كمان الفورث ventricle normal صح؟ يعني ده هيبقى كده non communicating hydrocephalus صح؟
اوكي يلا let's progress. Let's get going.
دكتور سؤال بس.
مين؟ عبد الرحمن. قول يا عبد الرحمن.
لا انا محمد يا دكتور
محمد. قول يا محمد.
دكتور الفورث فنتريكل هنا مش dilated هو كده مش dilated؟ الو.
ايوه يا محمد. فين الفورث فنتريكل؟ فين الفورث فنتريكل؟
اللي هو كده يعني.
لا ده مش الفورث ventricle دوت اللاترال هورنز
ده الهورن،
اللي
ده
هما
الهورن.
التمبرال اللي في التمبرال لوب.
امال الفورس موجود فين المفروض؟
الفورث هو دوت هنا.
آه.
طول ما هو شكله عامل كده يبقى مش dilated، لما بيبقى dilated بيبقى مدور.
هنشوف واحده باينه
أوكي.
اكتر من كده يا محمد يمكن.
طيب اوكي تمام.
طيب يلا let's get going. مين اللي هيورينا بعد كده؟ يلا يا محمد، عاوزين نشوف ايه اللي هنشوفه بعد كده.
هو بس اللي حط annotation ممكن يمسحها اللي لونها أخضر عشان بس نعرف مش ما تبقاش distracting.
طيب اوكي يلا.
اوكي
يلا يا نور what's going on.
ده chest x-ray chest to abdomen يعني يعتبر، بس أعتقد chest mainly.
بالظبط. Remember that if you want to x-ray the chest you need to x-ray
لازم
the
نبتدي
lower.
من النك وشوية في الابدومن.
بالظبط كده. بس because this is already their size is really small, you're almost x-raying the whole thing. The babygram طبعا it's not a babygram strictly speaking because you haven't got the limbs and you haven't got the entire head. But this is why we're actually x-raying the chest and almost the whole abdomen. Right? And what can you see? Is this a PA or an AP or a lateral or an oblique? What is it?
ده anterior anteroposterior.
Anteroposterior. The chest is usually a PA. The chest is usually a PA. A PA shows things much better than an AP. Okay. طيب what does it show? يبقى this is a plain chest, a PA. Okay. What does it show? And it's non-contrast. إذا كان الواحد يقول plain يبقى طبعا plain يبقى خلاص. قال plain يبقى it's some contrast. Yes. And what does it show?
It shows
أنا بس عاوز أقول حاجة معلش هلخبطك مرة تانية. يعني if there's contrast then you don't call it a chest X-ray. You call it بقى this is a bronchogram, this is an orthogram, this is a lymphangiogram. يعني okay. إن لما تبقى الابdomen you're reviewing the colon with the contrast you call it a barium enema for example, but you don't any longer call it a plain or chest X-ray. What does it show?
هو هنا الشادو بتاع الهارت مش باين، والمفروض كان يبقى فيه هنا مثلا الدايفرام، المفروض يبقى كان الشادو بتاع الهارت يبقى موجود في الحتة دي، بس apparently اللوبس بتاعت الانتستين مكملة للchest.
You can see
فدي
that there
hernia
are
مثلا diaphragmatic hernia.
You can see that there are bowel loops inside the chest. Is this what you're trying to imply? Which chest? There are which hemi-chest? Hemithorax يعني طبعا. The left hemithorax. There's the left hemithorax. Yes. And what would your diagnosis be? What is your diagnosis?
Diaphragmatic hernia.
Diaphragmatic hernia.
لا مش traumatic، مفيش أي حاجة trauma باينة، probably congenital مثلا. Congenital diaphragmatic hernia.
Congenital. Why did you say it's congenital? Why did you say it's congenital?
عشان مفيش أي evidence of trauma، وقلنا كمان إن ده بيبي صغير فالchest والabdomen وكل بالظبط
كده. لكن beware that if you say diaphragmatic hernia it's not conclusive because it may be traumatic. You know, in a maybe wider point of view it may also be hiatal, and hiatal is one type of diaphragmatic hernia. This is a congenital diaphragmatic hernia on the left side. مين اللي عاوز يقول حاجة؟
دكتور، وممكن عشان هي على الرايت سايد سوري على الليفت سايد، فده الموست كومن للسايت للكونجينيتال.
تمام. بس so is traumatic diaphragmatic hernias. Traumatic diaphragmatic hernias also develop much commoner on the left side because of the liver. لكن صح طبعا حازم بيقول that these types of hernia develop on the left side. يلا قولي لنا كده ريزيومي على why is it on the left side يا نور? Why do these hernias develop on the left side more than the right?
عشان قلنا الليفر بيبقى تحت الدايفرام في الحتة دي، فايفن لو الدايفرام مش معمول كده الليفر هو اللي ممكن يهرنيت فوق.
بس the other thing is that the left on the left side the pleuroperitoneal folds fuse later with the septum transversarium. They'll fuse later than the right. But that is why it's usually on the left side. It's usually on the left side. This is one reason, and obviously the other reason is the presence of the liver. Yes. What type of hernias do we have as a congenital type? What type? How many types have we got?
كان تقريبا 2
Yes, 2.
بوجداليك
ذلك وايه؟
ومرججني مش عارف.
ومورجاجني. لا do not just say مش عارفه at the end. It just casts a shadow that you don't know for no good reason when you know. يعني I know that it is protective to say that. I know. But try to avoid it because it adds nothing. It's either an anterior and the posterior. The posterior is called. How do you call the posterior one?
المرججني.
المرججني. With the anterior one?
بوجداليك.
Hazem wants to reverse. Do you agree or do you not want to agree?
أنا مش عارفة، أنا كنت أقول بالحظ الصراحة.
لا
مش عارفة مين اللي قدام.
البوجداليك هي البوستيريور. بالظبط. البوجداليك هي الكومن. البوجداليك هي البوستيريور وهي الكومن. البوجداليك. Okay. I'm repeating it just because I believe that this is one method of consolidating knowledge. If you hear something, then through auditory memory you can remember it. It's the Bogdalic and not the Morgagni. The Morgagni is rare, and it's a defect between the sternal and the costal origins of the diaphragm, and it's rare. Can you be sure whether it's an anterior posterior one in this image?
لا، عشان احنا شايفين انترو posterior مش شايفين من الجنب.
What do you want to get in order to identify its type?
Lateral view.
A lateral view, but because the Bogdalic is something like 90%, you probably tend to diagnose on this image. You probably tend to diagnose that it is
Bogdalic.
A Bogdalic one. Yes. في differential diagnosis. Is there a differential diagnosis for bowel loops?
ممكن نقول
ايه ال differential diagnosis؟
بقى traumatic بقى. تكون حاجة traumatic.
طيب يعني في الدي دي there are almost 2 points.
ممكن يبقى cysts في اللونج مثلا.
ممكن يبقى cysts in the lungs. اوكي. بس هو دايما الواحد بيقول حاجتين. What else could it be other than a diaphragmatic hernia? And if it's a diaphragmatic one, what type? واخده بالك ان the two questions فانت بتيجي تقولي دلوقتي DD of things other than a diaphragmatic hernia. This is one point. And then if it's a diaphragmatic, whether it's traumatic, whether it's congenital, whatever it is. طيب anything else? ممكن غير ال cysts of the lungs ممكن يكونوا bowel loops but without a diaphragmatic hernia.
مش عارف.
يعني افرضي واحد لقيتيه كده طالع له bowel loops جوه الشيست. Think about it. What sort of what lies superior to the bowel loops and to the abdomen? What is the limit of the abdomen?
Diaphragm.
Right. How about if the diaphragm is lies at a higher level? If the diaphragm is paralyzed and it lies at higher level, أو ساعات if there's this anomaly that we call eventration. I don't know whether you're aware of eventration when the diaphragm is a very thin sheet of fibrous tissue, and obviously if it's very thin, the bowel loops push it inside the chest. فساعات يبقى يعني عندنا دايما when we see bowel loops inside the chest, you want to make sure that it is a diaphragmatic hernia, not eventration or a diaphragmatic paralysis, a high cupola. But this seems to be going all the way into even the other side of the chest. It seems to be a diaphragmatic hernia. ايه مشكلة الdiaphragmatic hernia؟ بتعمل
دكتور هو
ايوه حازم قول.
هو حضرتك بتقول انه ممكن يبقى بارالايز، هو ممكن يبقى بارالايز on one side بس، يعني الاذر سايد سليمه جدا وما فيهاش حاجه وان سايد بس هي البارالايز.
نور تقدري تردي على حازم ولا ما تقدريش تردي عليه؟
لو الفرينك مثلا في الناحيه دي هو اللي اتقطع مثلا.
بالظبط كده. You could have injury to the phrenic nerve on one side.
طيب وبرضه حضرتك بتقول برضه ممكن يبقى evisceration. طب لو evisceration هنشوف اللوبس جوه؟
لا مش evisceration، بقول eventration. Eventration. مش evisceration. Eventration is when the diaphragm on one side I don't know whether it can be bilateral. I don't know. Is fibrotic and thinned out, and it's not contractile. And in fact, when the contralateral diaphragm contracts, the abdominal viscera are pushed upwards instead of downwards. And by time, the cupola that is eventrated bulges inside the abdomen with the bowel loops beneath it bulging inside the chest. Or sometimes when it's causing a problem, because obviously you can imagine it can cause a problem, it needs to be plicated. Plication is تتكشكش. Instead of leaving it redundant and immobile, you plicate it, it will remain immobile, but it will at least not allow the bowel loops to bulge inside the chest. Diaphragmatic eventration. Maybe in the traumatic situation, it's more difficult to diagnose. In this situation where you're dealing with a neonate, it's straightforward. طبعا it's a congenital diaphragmatic hernia. اوكي يلا هنكمل. يبقى CDH واحنا we're also revising the content of PEDS more or less. يلا نشوف ايه بعد كده.
هنا برضو تقريبا دي باول لوبس مثلا.
يعني دي باول لوبس. طب امسكيها كده، مسكتيها ولا لسه؟ لو هي
دي؟
باول لوب، is this a bowel loop? Is this a bowel loop؟ ولا this is an image of a bowel loop؟ بغلس عليك يا نور، بغلس عليك.
ايوه ده اكس راي chest X-ray
بالظبط كده. Because you're talking about the bowel loop. Where is it? A bowel loop in the abdomen. So what? But you're talking about the bowel loop that is present
chest.
Right? Chest. يبقى again, it's a problem. It's a problem again. Okay. You think that this is chest X-ray? What is the projection again? What is the projection?
Anteroposterior.
Anteroposterior chest X-rays are usually imaged PA and not AP. They're usually imaged PA.
Posterior. ماشي posterior.
What's happening?
في الباول لوب ديت، وغالبا هي عامله respiratory distress عشان في hyper inflation على الناحيه الثانيه. الناحيه الثانيه جت بلاك والريبس بعيده عن بعض وستريت، فبروبلي فيها hyper inflation شويه.
Okay. How did you know this is a bowel loop? How did you know this is a bowel loop?
عشان واخده contrast زي واخده contrast زي اللي دي مثلا اللي في الابدومن.
طب يلا قولي لنا what else could it be? You think this is a bowel loop inside the chest?
ممكن.
What type of bowel loop? What bowel loop is this type? What type of bowel loop? And what else could it be? دلوقتي عندنا اهو two questions. Could it be anything else than a bowel loop?
ممكن يكون مثلا ممكن يكون مثلا effusion مثلا pleural effusion والlung collapsed هنا.
Would look like that? Do you really think that effusion would look like that? Well, I think the lung is collapsed. Yes. I think the lung overlies.
لا لو effusion كان هيكمل حتى في الحتة دي كده ويعمل اللي هو rising level to the axilla.
Costophrenic angle. Can you see the costophrenic angle?
free.
Okay, if you don't think this is effusion and this is not the density of effusion, انت قلتي دي contrast. قلتي ده وضوح. This is contrast because you can see it inside the abdomen again. What else? This contrast can be where else? يعني انت قلتي ان this is contrast inside the bowel. Okay, inside the GI. قلتي ان دي ممكن تبقى herniated. ممكن تبقى ايه تاني طيب؟ ممكن تبقى ايه تاني؟ حاجة تانية؟ ممكن تبقى stomach. ممكن. Does it look like a stomach?
لا أعتقد إن هي طويلة على إنها تبقى stomach.
ممكن تبقى طويلة على إنها تبقى stomach. طب إيه تاني؟ What else could it be?
دكتور.
أيوة يا حازم قول.
transverse
هي ممكن دي تبقى اللي هي هرنيا بسبب المرجعجني ديفكت عشان ما بتبقاش سيفير قوي زي البوكتاليك، يعني هي لوب واحد بس اللي طالع.
ممكن. حازم suggesting this is a congenital diaphragmatic hernia. لكن هل دي ممكن تبقى حاجة نورمال طيب يا ربي ولا ما تبقاش؟
حاجة نورمال؟
يعني دي ممكن تبقى normal structure that is a bit dilated for example.
esophagus مثلا، بس ايه اللي هيجيب الاسوفيجس هنا؟
طب think out loud. You think this is not the esophagus. Why is it not the esophagus? Why do you think this is not the esophagus?
ايه اللي هيجيب الاسوفيجس كل المسافة دي والهارت هنا والتراكية في
You think
مكانها؟
that this is not the location of the esophagus. This is what you think. Okay, طيب خلاص. Think out loud. Think you should think out loud. Just think out loud. فيبقى this is not the esophagus because it does not lie in this area. The esophagus does not lie. Where does the esophagus lie? قولي لي كده في كلمة واحدة. Where
ورا
does the esophagus
التراكية.
lie? ورا التراكية. How do you
mediastinum.
put this area? Which part of the mediastinum?
posterior mediastinum.
بس كنت عاوز اسمع كده. The esophagus lies in the posterior mediastinum. This is not its location. Unless it's pushed somehow. يبقى it's not the esophagus. It is a bowel loop that you've been talking about. It's the stomach. It doesn't look at the stomach. Pradeep was suggesting that it could be the colon. It could well be the colon. You're suggesting that it could be a hernia. Yes, or whatever type. It looks like this man ممكن يشيل كل الارز اللي عملناها
بشيلهم
زياده منها معلش. عادي. The other thing, can it be an intervention? يعني دي ممكن تبقى intervention.
هو في تيوب غريبة هنا كده الحتة دي، معرفش ايه دي.
No, I don't think there's a tube. I think that this is a collapsed lobe of the lung and it's being collapsed. I don't think there's a tube. أو في tube صح؟
في جوه
صح في تيوب. دي فين التيوب دي تفتكر؟
اكمو، ممكن تكون اكمو مثلا. لو ديت صح. لو ده كل
ليه يعني what do you mean by ECMO? What do you mean by ECMO? Extracorporeal membrane oxygenator. With an ECMO, you've got a line in the artery and the vein, in the femoral artery and the vein, so that you get the blood out of the circulation. You vaporize it and get it into the machine that oxygenates it, and then you return it to the body. An ECMO. What else could this tube be?
Chest tube.
A chest tube.
underwater
tube. بالظبط. This is just a chest tube. زي ما Pradeep was saying, suggesting it's a chest tube, and he's right. طب يلا قلنا ممكن تبقى ايه تاني؟
دكتور، هو فين التيوب اللي انتوا بتتكلموا عليه؟
فندم؟
يعني ممكن حد بس يشاور على التيوب، انا مش شايف التيوب.
فين التيوب؟
بص في الحتة دي.
فين التيوب؟
الحتة دي كده.
بالظبط.
لما اشيل بتاع الانوتيشن هيبان احسن. هو حاجة كده في الحتة السوداء.
تمام.
شفتها يا حازم شفتها؟
يا دكتور شفته، شكرا.
اوكي. فانا برضو ما كنتش شايفها في الاول، لكن نور بينتها لي. I think that the lung is collapsed. I agree that the lung is collapsed. I think the lung is very close to the tube. شاورنا كده على مكان اللنج يا نور. شاورنا على مكان اللنج.
هي اللنج، الحتة اللي هي السوداء الكولابست على الهارت دي.
السوداء الكولابست. اللنج تبقى سوداء لما تبقى
لا، ممكن تكون يبقى البيضة
بقى. يبقى بقى الميديا اللي ده كده.
البيضة دي. ولا كلها؟
معك يا نور. معك يا طيب. يلا نور، ممكن تبقى ايه تاني؟ لا شاوري على اللنج يا نور من فضلك. Sure, lung, the
آه،
collapsed lung. The collapsed lung is
هنا
not.
بس هي تبقى
cool.
merged بقى شوية مع
أيوة.
مع الشادو بتاع الهارت.
ايوه طبعا، ايوه
فمش هنعرف نفرقهم من بعض.
لا بس هي كده الاوتر اند بتاعتها باينه. اوكي. The
دكتور.
less lines the better. ايوه حازم قول.
هي لو دي اللنج اللي هي نور شاورت عليها، امال ليه التشست تيوب مكمل فوق كده؟
يعني ايه المشكله ان التشست تيوب تبقى مكمله فوق؟ chest tubes are usually inserted in a
ما يبقوش جوه اللونج، يبقوا في
clear location if you want
البلورا.
to gain air and it's pushed.
البلورا.
ايه يا حازم؟
يعني انا قصدي انه هو التشست تيوب كده بعيد عن اللنج والبلورا.
لا it's put in the pleura and the area is radiolucent indicating that there is air. بس ما فيش حاجه اكتر من كده يعني.
اوكي تمام، فهمت.
يعني lung is collapsed, there is no
ايوه، ممكن
thorax.
يكون البيبي ده كان على فنتليتر، والفنتليتر عمل انجري مثلا لللونج، فده اللي عامل الناحية التانية الهايبر
Do you really think
انفليشن
that
برضه.
this boy is young? Do you really think that this boy is that young? Look at their bones and everything. Do you really think that this boy is that young?
مش عارفة، اصل حد هيجيله هيرنيا يكون ده
يبقى procedure. هل ده ممكن يبقى procedure? Can this be a procedure rather than a hernia? ممكن يبقى procedure. هل ممكن Pradeep was suggesting this could be colon. Could the colon be pulled into the chest?
ممكن يكون كان بيعمل مثلا اي اوبريشن، مثلا عملت تروما في الدايفرام فطلع الكولون فوق.
ممكن، لكن ممكن يكون a colon bypass. It could well be a colon bypass. يعني this is bowel inside the chest.
من الاسوفاجس يعني بتاع.
بالضبط. It is not the esophagus because it's not its location. There is evidence of an intercostal tube and there is evidence of lung collapse, which means that something has been going on in the area, whether it's traumatic.
ايوه، ممكن يكون مثلا البيبي ده شرب مثلا بوتاس او حاجه والاسوفاجس اتقفلت.
But I think that yes, it would well be that, and he's undergone a colon bypass or a colon interposition. طبعا you put the colon in different locations. It's not necessary to put the colon in the mediastinum. You can put it in different locations. Okay, these are the possibilities regarding this image, and it's not conclusive. بس انتوا طلعتوا data beautifully. You've been talking about an intercostal tube, been talking about an inflated lung, you've been talking hyperinflated lung on the concentrated side, you've been talking about a collapsed lung on the abscessed side, and you've been talking about this contrast-filled shadow within the chest that is not the esophagus, and it could be colon, whether herniated, whether an operated طبعا, or whether it's a colon bypass. Probably it's a colon bypass. يلا نشوف اللي
طب
بعدها.
دكتور، يعني هما ما بيحطوا الكولون بايباس، هما يعني بيكمبرومايز اللونج عادي؟
When you operate on the chest, you invariably get air inside the chest. It is invariable that when you perform a thoracotomy, you insert an intercostal tube as a rule in order to provide.
يعني لما الاير ده يطلع اللونج والكولون موجود هتشتغل عادي؟
لا، هتطلع تبقى مضغوطه شويه بس
تبقى كومبرومايز.
طب يلا يا نور. What about this one? This is an easy one. This is a straightforward one.
هنا في foreign body.
Okay.
هنا
where do you think it is?
في الفارنكس، في الupper part بتاع الاسوفاجس.
An ingested foreign body. Okay, and ingested probably coin. Yes, and how are you going to, who is going to remove it?
بيشيلوه بالاندوسكوب بقى اللي هو
تمام. يعني which specialty is going to remove it?
ENT.
ENT. If it's above the clavicles, usually the ENT. If it's below that, how about if it's below that? How about if this ingested foreign body lies below the level of the clavicles? That is.
نخش بقى بالاسوفاجوسكوب.
Who will do that job probably? A foreign body inside the chest.
يعني حد مش GIT مثلا.
Maybe. Okay, أو بقى the chest surgeons. It's either the chest or maybe the endoscopists, yes. But they probably need to remove foreign body. They probably need a rigid endoscope rather than fiber optic one. Okay, go on. Yes, this is not an uncommon problem. Elderly who are edentulous and ingest something that obstructs their esophagus, a bolus of food that obstructs their esophagus because they're edentulous and they have not chewed their food, or obviously children who are unaware of the gravity طبعا the seriousness of ingesting anything, and this is what happens. At times طبعا it's worse, and where does it lie? This is not very bad طبعا, it is bad enough, but at times it's even worse. And what happens to the foreign bodies? Where do they go?
ممكن لو دخلت بقى من التراكية وراحت للبرونكاي.
بالظبط كده، يبقى inhaled
راحت
طبعا.
mainly للرايت كده، للرايت
تمام.
برونكاي، وتقفل بقى اللونج تعمل كولابس.
طبعا this is much more serious. It can cause an acute emergency. It can cause a lung abscess later on. It can obviously reside in the larynx and it causes stridor. طبعا it's a major problem that needs urgent intervention. If you're getting an X-ray, you had the time and the luxury of getting an X-ray. But obviously this is an esophageal one or a digestive one and not an air one. يلا ايه بعد كده؟ دي ايه؟
ديت probably ده esophageal atresia، عشان عندنا الرست هنا هم حطوا contrast، فعندنا الرست للكونتراست في الحتة دي، وكمان الواير اللي لفت وطلعت. وفكرة ان هو
واير
لا اللي هي لا سوري التيوب اللي هو النيزو جاستريك تيوب مثلا، او حاجه رايل دخلوه او حاجه.
What type of atresia is this one? What type of atresia? Which configuration?
دوت
اللي
هو proximal. هو ده common، لانه في تقريبا فيستيلا هي اللي عملت هنا لا هنا ما فيش فيست. هنا في جاز في الابدومين واير في الناحيه الثانيه.
اوكي، ممكن برضو نشيل اللاينز الكتيره عشان ممكن تكون بتديسترب بعض الناس او لا، مش عارف. You think there's a fistula?
لا.
You think there's a fistula?
لا، ممكن يكون النمونيا ديت مثلا بعد الريجرج.
يعني you think there's a pneumonia? You think there's a pneumonia?
في نمونيا.
Why do
عشان
you think
في
there's
هنا
a pneumonia?
عشان هنا الكولر هنا غير الكولر هنا.
تمام، يعني
في هنا opacity.
Which hemithorax is this one?
Right.
The right hemithorax is there is opacity of the right hemithorax. If Noor thinks that there is an aspiration on this side. Is there a fistula? Is there a fistula? No fistula?
لا، في فيستيلا عشان في عندنا جاز في الابدومين.
بالظبط كده، يبقى the answer is whether there is a fistula or no fistula. If you look at the stomach and you identify whether there is air. If there's air, then there's no other way of the air getting inside the stomach except through a fistula. But this is the configuration, the standard configuration.
اللي هو proximal atresia مع distal fistula.
بالظبط كده، اللي هو distal esophagus fistulating with the trachea and the upper esophagus ending as a blind pouch. بالظبط. And the resulting air getting inside the stomach and the acid of the stomach getting inside the lung, and obviously the saliva that is being not swallowed is dribbling and it's frothy and it gets into the airway and causes an aspiration. All this stuff, you do not get these investigations done anymore. Is this an outdated investigation?
عشان مستخدمين contrast هنا، وما ينفعش نستخدم contrast عشان بيريجرج وبيعمل chemical pneumonitis.
بالظبط، because it becomes aspirated. تمام، خلاص. يبقى this was the year 1999. Okay, يعني something like 20 or 22 years ago. يلا ممكن نكمل. نور، انت لسه كويسه ولا؟
كويسه جدا.
هي كويسه قوي، الحمد لله.
الحمد لله. هنا بقى الكيميكال انجري للإسوفيجس.
Yeah, this is clear cut. This is clear cut. What is it?
ده chest x-ray posterior anterior view وواضح انه في barium meal مثلا لا barium swallow.
You would call this a barium swallow. You would call this a barium swallow. You wouldn't call it anymore a chest X-ray. You would call this a barium swallow. Yes.
Okay.
And what is the esophagus continuous with?
الاسوفيجس وقفت هنا وغالبا ده بقى الكولون البايباس اللي هم عاملينه.
The colon, yes, the colonizing
ايوه
the
اللي هي
chest.
الحته دي.
With the esophagus, yes. Well, how did you know this is the colon? Why is this the colon?
عشان المكان اولا ده مش مكان الاسوفيجس وكمان اللي هو الهاوستريشنز.
It's the hostrations, absolutely. It's the hostrations. So these are the typical hostrations of the colon. In children, hostrations may not be as clear as in adults. The colon may be a bit ahostral in children, but it's not the case in this situation. The hostrations. How do hostrations develop? How do hostrations develop?
عشان التينيا كولاي.
Yeah, what do you mean by okay? What are the tinea coli?
دي اللي هم المسلز اللي في الكولون وال بيبقوا 3 كده.
Which muscles? The circular or the longitudinal?
هم longitudinal.
Longitudinal. يبقى they're this continuous layer that forms 3 bands. And okay, and how do they create the hostrations? How do they create them?
لا هو probably كده يبقى الهاوستريشنز عشان الcircular muscles هي اللي ممكن تعمل هاوستريشنز.
لا خالص.
تينيا كولايسا؟
عشان they're shorter. Because they're shorter.
they're shorter عن طول الكولون.
They sort of placate the colon in a very irregular, haphazard method that we call the hostrations. This is again a colon bypass, or in which would you prefer to perform a bypass or an interposition? Which is the preferred form of treatment?
الانتربوزيشن ده لو كنا بنبول الستومك صح؟
لا الانتربوزيشن اللي هو you
بنركبهم مكانها؟
you remove and you put the conduit, you join them to the ends. But this is interposition, a bypass, you just leave it behind and you anastomose it side, end to side, above and below. Which is better, an interposition or a bypass? يعني in other words, are you keen on removing the pathological esophagus? Would you like to remove the pathological esophagus or not? Why would you rather remove خلاص بقى فضلنا this last session بقى لغايه ما يقطع عندنا 40 minutes يا محمد ولا انا كام minutes؟ محمد the session lasts 40 minutes ولا
40 minutes
40 minutes ايوه
40 minutes فندم
40 minutes ايوه
Okay, we've got 40 minutes back to go, which gets us almost to 11. يلا why would you rather remove the esophagus يا نور؟
ممكن تقلب malignant.
بالظبط it's cancerous. And why don't you usually not remove the esophagus يا نور؟ يعني your answer is correct.
عشان
yes.
بتبقى عاملة fibrosis ممكن مع important structures في المكان.
بالظبط because it's really difficult. Yes, it's ideal to remove it, but it's very serious removing it. It's very dangerous because it's stuck to the mediastinal structures because of the fibrosis. Obviously, the inflammation that is caused by corrosive does not stay limited to the wall. It extends to the outside, and it's a type of a burn, and so forth. So it's at times really difficult to remove it. A lot of times you will perform a bypass and not an interposition, although an interposition seems to be the ideal. Are corrosive strictures still common nowadays? Are corrosive strictures still common nowadays?
لا عشان الناس بطلت تستخدم الكوروزيفز في التنظيف او كده
Because
مش زي زمان
much less people are aware and they don't use it a lot. It's much less. It's something like 30 years ago, it was a real problem. Nowadays, it's much less of a problem. Okay, probably this is an interposition because it seems to be that the esophagus is joined end to end to the colon. Okay, yalla, let's proceed. We have reviewed a few things this morning. يلا قول لنا دي على طول فضلك.
ديت برضو اتريزيا اسوفيجيال اتريزيا وزي اللي فاتت برضو لان في جاز في الجاستريك اير بابل وبرضو في pneumonia on the right side.
This configuration
X-ray posterior X-ray.
Okay, but will this يعني this configuration of the pathology contributes to what percentage of
85
87 or 85 absolutely the vast majority. Yes, يلا let's proceed. يبقى hydrocephalus, how do you call it, craniosynovial, CDH, TOF. يلا نشوف عشان foreign body. يلا ممكن نكمل. ايوه
هنا في esophageal stricture هنا هنا الكونتراست barium swallow. الكونتراست هنا كتير وبعد كده بيتيبر لتحت في stricture فبروبلي ده برضو corrosive.
This is a corrosive stricture. What are the criteria of benign stricture anywhere in the bowel? What are the criteria of benign stricture?
Benign stricture هيبقى يعني هيبقى قبلي
a stricture that may be benign or malignant very broadly. What are the criteria of a benign stricture?
إنه قبليها في حتة واسعة وبعد كده بيبقى في funneling كده بعدين collapse.
Funneling يبقى it's gradual. That is to say there are no shoulders and the dilatation above it is marked because there are no, in a benign one there are no shoulders. In this one it is doubtful whether there's shoulder or not, but in a benign one there are no shoulders. I don't know whether Pradeep was, what did you mean Pradeep, whether you mean that this is not very typical because there may be a bit of shouldering, but in general a benign stricture has got a few characters. That it is above it, there's marked dilatation. The stricture itself is central. It is regular. It is long. There are no shoulders. Probably زي ما تقولي كده this is a benign stricture because it is extremely long and it starts in the middle esophagus. What do you think it could be?
Corrosive.
A corrosive stricture. Yes, طبعا. The age is very, very important because if you're talking about a child, you don't consider a malignant stricture in the first place. But if you're talking about
والmalignancy بيبقى probably تحت مش فوق في الاسophagus.
But it doesn't mean that it is exclusive to the lower part or the middle part. You almost always need a biopsy. You cannot diagnose strictures of the esophagus unless you biopsy them. But not in this age group. In this age group, it's a very straightforward diagnosis that it's supposed corrosive stricture. طب يلا
وبالهيستوري برضه ان هو شرب حاجه
بالظبط كده. طبعا عشان كده بنقول this is very, very important. You don't interpret images by the findings per se. You have to diagnose them using history taking and so forth. يلا كمل يا محمد من فضلك. شوف اللي بعد كده عندنا ايه.
هنا اللي هو أكاليزيا دوت برضو chest x-ray وهيبقى عندنا اللي هو البيرد بيك appearance ان هو من هنا في حتة dilated dilated وبعد كده في suddenly الدنيا اتقفلت.
يعني you think it's a benign, don't call it achalasia, just call it a benign or a malignant one first of all. Just call it whether you want to diagnose a benign or a malignant one first of all. You
benign.
think that this is a benign stricture? Why is it
أيوة.
not achalasia? Why is it not achalasia? It's marked dilated above. It's gradually tapering. There's no shoulder. Appearances may be very deceiving. You have to biopsy them. It is in the middle. It is regular. It is a long stricture. Why could this never be achalasia?
أنا حاساها achalasia لأن في اللي هو bird beak appearance.
You think it's achalasia? You think it's achalasia? Do you want to have a second thought? Why could this never be achalasia?
يمكن عشان إنه التضييق ما كانش gradual جه suddenly كده الدنيا اتقفلت.
لا it's not sudden. انت عملت عليها taper اهو. It was that big and then it became that smaller and then smaller and then it completely diminished. It did not occur suddenly. It's not so sudden. But why couldn't? Where is the site of achalasia? Where does achalasia occur? Is this the site of achalasia?
في ال upper part. لا أنا اديت كده في ال lower part أو medium part.
Where does achalasia occur? Where is the site of achalasia of the cardia?
فوق.
Table of the cardia. فوق.
أيوة. لا.
The cardia.
The cardia يبقى عند فتحة الstomach. عند اللي هي عند الكارديا الحتة اللي هي الأوبننج اللي في الدايفرام.
بالظبط. يلا يا نور. You expect the achalasia if it's narrowing to occur at the level of the esophagogastric junction. It's just the diaphragm, but this is too high for that. يلا يبقى again this is a benign stricture that could well be اسمه ايه post corrosive, maybe not. يلا we haven't got enough evidence to say that, but it's a benign one. يلا يا محمد كمل لنا يا محمد من فضلك. سيبك من دي دي مش مهمة. يلا يا نور. What about this one?
ديت تقريبا chips. عندنا هنا الستومك فيها بيريم ميل وبعد كده عندنا هنا الدنيا ضاقت.
فين هنا الدنيا ضاقت؟
عندنا هنا اللي هو الشولدرنج عندنا هنا اللي هي الحتة الشولدرنج.
How do you call? What do you mean by shouldering?
shoulder sign. shoulder sign وبعديها
Yeah. Well, what do you mean by it? يعني what do you mean a shoulder? What do you mean by that?
إنه الدنيا ضاقت فجأة يعني وبعد كده بقى فيه بس هو outlet صغير خالص اللي هو السترينج تقريبا كان اسمه string sign.
It's abrupt change from to a narrow point. How narrow is the pylorus?
Very narrow لأنه عامل اللي هي اللي بيسموها string sign تقريبا.
It's a string sign. This is the string sign. وطبعا there is a bit of contrast past the pylorus into the duodenum, but it's scanty. This is what we call the string sign. What is the string sign? what does the
اللي هو
string sign imply?
إن هي الفتحة صغيرة قوي، الكنال اللي هو ماشي فيها الدايمتر بتاعها صغير خالص.
Whenever the lumen of hollow viscous becomes reduced to a really narrow part that is similar to a string, it is called the string sign. But whenever the lumen of a hollow viscous becomes very much reduced to the size of a string, it's called the string sign. Is it specific? Is it specific to this disease only, to chips only?
لا، اي حاجه ضيقه يعني حاجه اي ليومن كده ضيق كده يعمل string.
بالظبط كده. يبقى if the lumen or viscous becomes narrow to the level, to a marked level simulating a string, it's called the string sign. Even in an artery, if the lumen of the artery becomes really narrowed, طبعا narrowed, not a focal one, because the string will not be a focal one, narrowed and long. لأن لو focal مش هتبقى string. Obviously, string is not a very short thing. But it has to be long and narrow, just like the carotid. If there is minimal flow in the carotid, it's called the string sign. If there is a minimal flow in the small bowel, as in Crohn's, ايه اللي بيعمل stricture of the small bowel يا نور؟ ده لسه قايل. What is the most common cause of a stricture of the small bowel?
احنا الكرونز.
الكرونز. Crohn's. Well, Crohn's reduces the lumen of the small bowel into a string, and then it becomes the string sign. They call it the string sign of Cantor. But the string sign refers to the fact that the lumen of all viscous becomes narrowed, markedly narrowed, simulating a string over a length of the bowel. يلا هنكمل. يبقى this is زي ما انت قلتي chips. What is the presentation?
chips البرزنتيشن هتبقى جاي delayed bilious vomit. لا مش bilious. delayed non-bilious vomiting.
تمام. طب يلا واللي بعدها دي كمان. يلا. Do you still get contrast images in order to diagnose the chips?
Probably لا.
You don't get them anymore.
بنحس اللي هي الأوليف ماس اللي في
You feel it, and
في
if you want to confirm it, what investigation do you request? A mass in the abdomen. How will you confirm a mass in the abdomen? By an easy method.
ultrasound.
You get an ultrasound. I would get an ultrasound. If you're sure of the lump that you felt and the clinical picture dictates, then you can operate. I will get an ultrasound. Ultrasounds are not an investigation. Ultrasounds are adjunctive to clinical investigation. يلا ودي يلا قول لنا what's happening with this image.
هي الاسوفاجس شكلها مش طبيعي.
فيش حاجه الاسوفاجس مالها.
لا ده كده ده نفس الحاجه.
مفيش تيوب في الاسوفاجس.
في تيوب. ده تيوب. لا في تيوب عشان في ديت باريوم ميل.
اوكي.
بس هنا ايه probably البايلورس مسدود خالص، مفيش even string.
مفيش.
وباقي الابدمن ما فيهاش.
يعني maybe it's a timing, maybe it's just a timing. What do you suggest as the diagnosis?
برضه chips congenital hypertrophic pyloric stenosis.
It's better called hypertrophic pyloric stenosis because it can be infantile, and at times the same pathology develops in adults, by the way. لكن طبعا it's most commonly congenital, but it can at times be infantile. فأحسن الناس يقولوا hypertrophic pyloric stenosis and they stop at that. يلا ممكن نشوف اللي بعد كده. يلا what about this one?
هو هنا ممكن ده يكون مثلا الاستومك كلها مليانه هواء distended قوي.
First of all, is this a plain film or a contrast film like the others?
لا plain film.
It's a plain film. It's almost all the baby. It's the chest and the abdomen and the thighs at least. Yes. And what's happening?
stomach distended. ده ممكن يكون اللي هو الدبل بابل.
The double bubble, yes. Where is the other bubble? The stomach is full of air. Where else is full of air?
في الحتة البروكسيمال first part بتاع الدودنم.
فين هي؟ شاوري عليها.
اوكي اهي بابل دي هنا دي
أيوة.
الستومك اهي ودي البابل التانية.
Okay, is this infant or this neonate, are they sitting or are they standing or
اكيد
is it
اكيد
erect or
لا لا اكيد supine
supine؟
نايمين.
يلا. Okay, صح. Double bubble, you'll see a better one in a minute. يلا I hope. يلا let's proceed. دي نفس الحاجة بقى. خلاص بقى this is again ودي
برضو
typical strain sign. يلا خلاص خلصناهم بقى. لا we'll not review these anymore.
دي دبل بابل واضحة
اهو
جدا.
دبل بابل اهو دبل بابل. يلا لا في بس واحدة فوتناها. في واحدة فوتناها أعتقد. في واحدة دبل بابل. هي دبل بابل وهي ده
دي
واقف
دبل
ولا
بابل.
قاعد؟ ده واقف ولا نايم ده؟
نايمة. كل الحاجات الكونجنتال دي
ده
بيبي
نايم
الصغيرين
ده؟
ما بيعرفوش يقفوا.
ده تفتكري نايم ده؟ ده تفتكري نايم؟
لا واقف. بس وقفوه ازاي؟
يعني مش عارف يعني أقصد أقول
اوكي.
you can move the table. You can move the table. You can support them and move the table. Well, they've already got what have they got inside their abdomen? What have they got inside their stomach يعني؟
Tube.
An NG tube, yes. Double bubble. The rest of the
abdomen is gasless.
بالظبط كده. And there are only two air fluid levels, one in the duodenum and one in the stomach. Typical double bubble. What is the presentation?
هيبقى عنده bilious vomiting.
When?
Early.
What do you mean by early? What do you mean by early? What do you mean? How many days or into neonatal life? How many days?
يعني 3-4 أيام مثلا.
2 to 3 days. 2 to 3 days. How about chips? What is the timing of vomiting in chips?
ممكن weeks, 3 weeks.
2 to 3 weeks. The 2 to 3 days, but 2 to 3 weeks, if not more than that. Okay. Yalla. Okay. Double bubble. Lovely double bubble. Yes. Typical presentation of an image that depicts a double bubble. Okay. Go on. What is the treatment of adrenal atresia?
Surgery. هم يعملوا recanalization.
What is the surgery? Yes, it's surgical. What is the surgery?
بيقطعوا. هو دايما بيبقى فيه septum كده سادد المكان فبيفتحوه.
Very difficult. The duodenum is very difficult to. There's no extra length. It's very difficult to resect and to re-anastomose, particularly that there is a very important structure lying in close proximity to this area. What is it? What are the important structures that lie very close to this area?
بيبقى فيه الأمبولا أوفاتر والبنكرياس.
بيبقى you wouldn't do that. What are you going to do? You leave the area of problem alone, the arthritic part alone. What do you do?
بنأنستموز قبل السدة. يعني بناخد مثلا البارت الجيجنم مثلا ونأنستموز قبل السدة.
Why is it not ideal to anastomose the jejunum to the duodenum? This is not the best thing to do. What happens if you anastomose the duodenum to the jejunum? What happens to the rest of the duodenum all the way down to the jejunum? What happens to this part when food will go from the duodenum above the arthritic part to the jejunum below? What will happen to the loop in between? Will the loop in between function? Will it function or it will not function?
اللوب ما احنا مش احنا عملنا له exclusion.
It will not function. It will not function. And if it doesn't function, there's a good chance that what proliferates in it? What
bacteria?
Bacteria, the blind loop syndrome. The blind loop, you're not after creating blind loops. You rarely, at times you have to, but it's not the best thing to perform, particularly in this age group. You'd rather anastomosis the duodenum to the duodenum above to the duodenum below, not that you anastomosis it to the, طبعا anastomosing to the duodenum is easier, but it's got this major disadvantage of creating a blind loop. طب يلا again يلا هنشوف اللي بعد كده. يبقى خلاص it's the same thing. يلا شوف لنا دي بقى ايه دي.
دي اللي هي دي اللي هي كانت مشكلة من الفنتليتر، كان بيسموها اير سيندروم حاجة كده، ان هو بيبقى الاير تحت حوالين الليفر حتى فاصلها من الشيست وال.
يعني what is the image? Why don't you start commenting on the image? What is the image?
The chest X-ray posterior view of the abdomen.
Chest X-ray? Is this just a chest X-ray?
لا مش chest، لا ده baby gram ولا كان اسمه؟
It's almost a baby
chest to
gram.
abdomen.
It's the whole torso and more. The upper limbs are almost included. It's the pelvis, it's the abdomen, it's the chest. And what about the chest? Is the chest domain being lost? Is the volume of the chest much reduced?
أيوه.
It's much reduced. Okay. And how about the abdomen? What's happening to the abdomen?
الابدومين distended جدا.
It's distended. Okay. And what does it contain? زي ما انت قلتي air. Free air. Is it free air?
عامل حتى separation للليفر اهو من هنا عن الشيست وال.
يبقى what is the diagnosis?
اللي هو pneumoperitoneum مثلا.
This is a pneumoperitoneum in children or in infants in this age group. This is the appearance. It's not like in adults. In adults, this appearance is quite rare, but because of the diminished domain of the abdomen in children, this is the appearance. The air fills the whole abdomen, surrounds the liver, simulating as if it's the chest and the heart. But this is pneumoperitoneum for whatever reason بقى. ايه اللي بيعمل pneumoperitoneum؟ قلنا كده what is the cause of a pneumoperitoneum؟
ممكن انه مثلا باول لوب يحصل لها perforation.
perforated لازم باول لوب يعني ولا ممكن تبقى حاجه غير الباول لوب؟
فيسرا.
هولوفيسكس. perforation of هولوفيسكس. What else is the cause of pneumoperitoneum؟
ممكن مثلا stab wound.
stab يعني air from the outside. air from the outside. a stab or
ممكن complication ممكن complication من الفنتليترز.
complication of ventilators is usually a pneumothorax.
احنا كنا خدناها قبل كده في الأطفال إن في حاجة كانت بتعمل نيوموثوركس ونيوموبريكارديوم ونيوموبريتونيوم كلهم مع بعض.
ممكن بس يعني في الأطفال ماشي. طب إيه تاني غير البرفوريتد فيسكس؟ لكن قلت لي تروما والستاب. إيه تاني تروما؟ إزاي ممكن تيجي تروما تدخل هواء جوه البطن تاني؟ one type of trauma that we all do all of the time.
اللي هو لما يعملوا لاباروسكوبي بينفخوا الابدومين.
لاباروسكوبي. وطبعا لاباروتومي even the laparotomy when you open the abdomen طبعا and it's important because if you find air post-operatively, if you x-ray someone post-operatively for even up to 5 days post-operatively, you encounter air, doesn't mean that the bowel is perforated. It means it's just this is the air that has been introduced during the operation. It's not a big issue يعني. Okay, so this is pneumoperitoneum.
دكتور هي ليه الحتة دي جازلس خالص؟
مش عارف. It may be the rest of the liver going down. يعني the bowel loops are being pushed to the other side. Maybe this is fluid. I haven't got a good explanation for why this is completely gaseous. Probably this is the condition of the liver. Maybe, I don't know. But the lungs are normal. The lungs are just pushed and there is a pneumothorax. فدي حاجة من البطن بقى whatever it is, perforated viscous for whatever reason. بقى valvus venatorum, meconium ileus, whatever بقى cause perforated bowel in this age group. يلا نكمل. يبقى we've reviewed things like a nephroblastoma, a neuroblastoma, Pott's disease, Burkitt's disease, an ingested foreign body, a congenital thoracic hernia, a TOF, a CHIPS, colon interposition, stricture of the esophagus that is of the post-corrosive type, duodenal atresia. يلا قولي لنا دي ايه؟
هنا مفيش لا دي gastric air bubble اهي. هي دي كده gastric air bubble صح؟
مش ايوه this is the gastric air bubble. Is there any other
لا gasless abdomen.
gasless? Is it really gasless or is there another
في حتة
airflow
صغيرة
bubble؟
هنا.
فين؟
هي دي كده ايه بتبقى double bubble؟
دبل بابل
صغننة.
دبل بابل صغيرة نعمل لها ايه طيب؟ دبل بابل برضه. Okay, you can see how the vast majority of the abdomen is of the body is being imaged. It's the pelvis and the thighs and maybe the legs and the abdomen, the torso, the entire torso. Torso طبعا trunk. Let's continue. These are the things that we've been reviewing. They're all pediatric things. بعد الأجازة بقى we'll start again with CTs. We'll continue the CTs that we've stopped for the sake of the peds. يلا نشوف محمد هيحط لنا ايه تاني.
ايه ده؟ هو ايه ده اصلا؟
مش عارف شوفي انت كده.
هو كده في السباين هنا، دي الحاجة اللي انا قدرت اتعرف عليها هي هنا.
دي مهمة. It's the bone that you need to identify. It's the bone. The bones are very, very important. They are the constant, the most constant structures inside the body. At least this is the spine. Yes. Can you identify any other bone? Is this the lumbar spine, the thoracic spine? Identify bones in this image again. Can you see any other bones in this image? Can you see any tubes?
هو في مش عارفة إذا كان دي تيوب ولا لأ.
فين؟ شاوري عليها.
أهو حطيت خط هنا بس مش عارفة ايه ده.
Do you think this is a tube? Where is the tube? I don't know whether this is a tube or not, but where is it coming from? Even if it's a tube, where is the tube coming from? The main tube is coming from.
هو في براديب شاور على حاجة هنا.
Okay.
إنه في هنا ده string مثلا أو حاجة.
Can you identify any bones in this area? Can you identify any bones in this area?
هل ده مثلا symphysis pubis مثلا؟
Can you see obturator foramen and the femur and so forth?
اوكي يعني ده كده دي الإليم مثلا؟
ايوه دي الإليم. فين الإليم؟
اللي هي دي كده واللي في النص دي obturator.
انا مش عارف انت بتشاوري على انهي افلام دلوقتي، ما انا مش عارف، انا اتلخبطت. ممكن نشيل كل الماركينجز دي وتشاوري على حاجه ثانيه عشان انا بقيت the image where you've shown your vertebrae.
دي الvertebrae.
The lower part of the image identify any other bones.
يعني مثلا هنا دول الإليم اللي على الجنبين دول اللي هو الهيب بونز ولا ايه؟
يعني بس I can see them. They're probably there, but can you see the obturator foramina and the hip bone, the pubic bone in the lower part?
مش شايفة obturator دي مثلا دي obturator foramen.
اهي لا خلينا في فيلم واحد اللي هو الفيلم اللي انت مشاور على الفرتبري. اوكي. و can you see a tube coming from below? Can you see a tube coming from below?
ده
ايوه this is coming from below and this is the hip bone. يبقى what is the study? What is the study? There's a catheter getting inside.
Enema.
This is
Enema.
a barium enema. دي barium enema. اوكي دي barium enema. روحي بقى للفيلم the very first, the lowermost film in the row that you were pointing at on the superior one. يعني the row.
ايوه ده
روحي انزلي بقى لتحت خالص. ايوه. ويلا قولي لنا what's happening with this one. This is
هو
a lateral
هنا
view.
في
lateral view.
في هنا الدنيا كانت واسعة قوي وبعد كده قفلت.
احنا بنبتدي من تحت لفوق، فشاري من تحت لفوق. من تحت كانت الدنيا مالها؟
من تحت في اهو هنا في حتة ضيقة يعني او channel صغيرة.
وبعدين هنا وسعت قوي وبطريقة gradual. Can you see the sacrum? Can you see the sacrum? Can you point to the sacrum?
في نفس الصورة.
digital and السكرم ورا هي موجودة. These are all digital films and they are subtracted. السكرم موجودة ورا، شايفاها ورا؟
اللي هي أنا شايفاها أيوة. هنا هي دي كده.
فين؟
على الصورة اللي جنبها. ما دول
بس
vertebra باينين بس
الصورة اللاترال، على الصورة اللاترال دي اللي أنت قلتي فيها حتى narrowed and حتى أنا dilated part. Point towards the sacrum. You can see the sacrum behind. You can see the sacrum and you can see the thighs even. أيوة this is the sacrum.
الحتة اللي في النص يعني.
But not all this triangle, the lower part. It's just the lower part. It's just the lower part. The lower part.
هنا. هنا.
أيوة. لا مش هنا. Lower where Pradeep was pointing.
هنا.
It's much lower. أيوة. اللي عاطف شاور عليها. This sacrum. What is the disease then? This is a young person obviously, and they've got this narrowed rectum and then gradual dilatation of the sigmoid.
Hirschsprung?
The Hirschsprung. The Hirschsprung. This is a barium enema and this is a Hirschsprung. The Hirschsprung. Okay. Maybe difficult to identify. أو في الفيلم اللي towards your right hand side, the lowermost image, the one that you're pointing to. أيوة شايفة السيجمويد. Show us the sigmoid. Where's the dilated sigmoid? Absolutely. أهو S-shaped sigmoid. It is dilated. Okay, Hirschsprung disease. We've discussed this in a lot of detail. Noor Olili, I know that you've become exhausted and we're coming to the end of the session. We may have not finished, but we'll finish obviously in a few minutes. We'll continue about whatever we'll continue inshallah. Next week is vacation, the week after next. So what is the risk of operating upon the rectum? What is the risk of operating upon the rectum? Whenever you operate upon the rectum, what is the risk?
إن ممكن injury للlower part بتاعه يعمل incontinence للحتة اللي فيها
الsphincter. Whenever you operate upon the rectum, you worry about incontinence. Whether it is your actual, you may injure the bladder, but it's much more about continence. It's you're between two hazards: a hazard of leaving pathology behind and the hazard of causing incontinence. طبعا the closer you are to the dentate line, the more incontinence you cause. طبعا you can imagine that infants or children who are operated for Hirschsprung have got the risk of a bit of incontinence. How about in a man? If you operate upon the rectum, what do you risk? What nerves can you injure in a man? in a man?
النيرف اللي هو pudendal.
يعني what will they cause? What if you operate upon the rectum in a man? Impotence بالضبط. أو قلنا بدل impotence we call it how do you call it in a better way rather than impotence? Impotence is one final outcome, but it can be a spectrum. That is why how do you call it?
Erectile dysfunction.
بيقول عليها ED بيسموها erectile dysfunction بدل ما تبقى impotence, because it's a spectrum and because the word impotence is not a very nice one. But if it's ED, it's much better. So you call it ED حتى بيقول عليها ED وخلاص. But remember that operating upon the rectum almost always carries two risks. it carries the risk of incontinence, and in a man it carries the risk of you may injure the nerves of the bladder زي ما عاطف قال, but not the bladder itself. You can injure the bladder obviously, but this is not the common thing. But you can injure the nerves to supply the bladder, and the bladder may suffer a bit of neurogenic effects. اوكي يلا خلينا نخلص يا محمد من فضلك عشان ما قدرنا نعمل اكبر جزء. we may be left with a few. ما يجراش حاجه. we are not late, we are just لا اللي قبلها شويه ورينا. طب يلا ورينا
دي كلوساين.
يلا يا محمد اللي بعد دي على طول. ايوه يلا قولي لنا دي ايه.
دي برضه هير سبرونج.
ده برضه هير سبرونج. a boy, a girl, an adult.
لا حد صغير.
حد صغير
عشان الابيفيسز ما كانش مقفول.
حد صغير بس الايمج دلوقتي اوكي يعني this is not her sprung, this is an image of her sprung, this is not her sprung. This is an image. What image is it? What image? You did not talk about the image at all. What form of image?
X-ray.
X-ray. Okay. Contrast X-ray ولا non-contrast X-ray?
لا contrast. تبقى barium enema برضو.
This is a barium enema. What is the projection? What is the projection? حازم يقول lateral. إيه رأيك? Can you see the sacrum again? Can you see the sacrum?
هو حاسه ان هما اتنين مختلفين. يعني هنا في كأنه اتنين فيمرز، انما هنا في اللي هو الهيب بون وبعد كده فيمر واحدة. فممكن يكون
the positioning, but how about the sacrum? Where's the sacrum? Where's the sacrum?
السيكرم ورا اهو.
طيب يبقى ورا. يبقى ايه ورا ومفيش حاجه
دي الهيب
جنبه.
بون.
يبقى ده ايه؟ يبقى ده lateral ولا اي بي ولا ايه؟
lateral.
يبقى ده lateral. Both are lateral, and you can see the narrowed rectum in relation to the. You can see the narrowed rectum in relation to the
sigmoid.